that boy? What is it? Oh, shivering boy. Okay, outside? So, I think we're just going to jump right into this subject because it could be a little bit lengthy. First off, I'm going to set some ground rules for myself. I'm focusing on the history of obstetric practices, what it was, when it changed, and why it changed. I'm not going to get into politics. I'm going to keep myself from getting off into tangents because I have an awesome editor that will cut me off. Whenever I'm talking in current times, I will use the term birthing person because there are some female to male transgender people that have given birth, and I acknowledge that. It's a fact, it's a reality, and they have their own personal experiences. When I talk during time periods in the past when that didn't happen, I'm going to more often slip and say mom. Unfortunately, at the bottom of this list, I'm going to get into some things that are still continuing. They have not stopped. They may have modified a little bit, but they have not stopped. Obstetrics, the medical focus of obstetrics is to not just sit, watch, and wait. This is called active management, and it doesn't work as well with maternal medicine. It might work better for other kinds of medicine, but not for obstetrics. Midwifery has found for centuries that what's called expectant management is much better. That means that if there's not anything going wrong, if there's not any indicators that something might be going wrong or getting ready to go wrong, then we sit back and wait and let nature take its course. Because nature knows best how to make these things happen. We don't modify periods unless they are intense or something's going wrong with them. So why do we do that with labor? The only reason? Because there's a baby involved. Babies should always be protected. But in order to keep that baby and its birthing parent safe, we need to not push labor or intervene on labor if everything is going well. And going well does not mean the Friedman's curve. Friedman himself admitted it later. You can't predict that cervical dilation will happen 1 centimeter every hour. It doesn't work that way. For sure, obstetrics relies on procedures, practices, medication, tools. I'm going to get into this much more in depth, but I really could not say it any more eloquently than the late Dr. Marsden Wagner.
In the 1930s, they were giving x-rays on every pregnant woman to measure her pelvis. And then in the 1940s, they discovered that caused the baby to have cancer. So they had to stop it. And then in the 1950s and 60s, they had another drug called thalidomide, which caused babies to be born without arms and legs. And then they had to stop that. But you see, in every case, it was after the fact. In the 1990s, they were giving Cytotec to induce labor in women who had had a previous cesarean. And they ended up with hundreds and hundreds of ruptured uteruses and many dead babies before they found out, finally, in 1999, that they shouldn't do that. But you see, there's not a good history in obstetric practice of careful study of the long-term effects of all these interventions.
Midwives were managing the childbearing year for eons and eons until the medical industry started to develop in the 1700s. And physicians started to intrude on the birth room. And as they were learning and practicing on women, they were going from autopsies, sometimes autopsies of pregnant women, to a labor, doing a cervical exam, and not washing their hands. Because this was the era before gloves, obviously. But most moms, most women during this time, just in the the process of daily women's work wash their hands on a regular basis. So that's already a natural aspect of having daily life. So what happens? A lot of moms and babies get sick. The layman's term for it is childbed fever. And this happened throughout the first half of the 19th century. And it wasn't until several studies were published, finally one of the last ones by Semmelweis in 1861, had been repeatedly saying this is the source of the infection that's killing women and babies, that's causing childbed fever. It's coming from autopsies. In the meantime, for those decades, these physicians, not even called doctors then, were blaming everything on midwives. We have showed up to so finally, in the late 1800s, doctors started washing their hands, and childbed fever dramatically decreased. Oh, I am not going to enjoy, I don't enjoy any of these, but I'm not going to enjoy this next topic. Dr. Marion Sims, one of those new doctors in the 1800s, and he was not the only one, but was well known for this practice, utilizing enslaved women to practice gynecological experiments on them. So, that's how gynecology got started. Specifically from the experiments and the things that he learned from experimenting on enslaved women started from that. Pelvimetry is basically the act of measuring different aspects of the outside and inside of a woman's pelvis. My first time using this. Night-night, little baby. There are all sorts of different measurements that are made in pelvimetry. Doctors theorized that those measurements would make certain predictions about labor. So as those measurements were studied on cadavers, accurate measurements still can't be made on a pelvis that's still, that's not in labor, a pelvis that is laid against a bed or some kind of surface, because the measurements that are made under those circumstances still don't give a real picture of what actually happens to that pelvis in labor. There's not really a good date that stopped. I don't know that it's completely stopped. It's still taught. It's been a while since I've heard a woman say that a doctor made a comment about the size of her pelvis. So in the early 1900s, what happened was this new medical tool, the X-ray. I don't know the history of this stuff. I'll leave those with the medical students. This X-ray was used on pregnant women, aiming X-rays at her pelvis to make measurements of her pelvis. It was a routine practice in the early 1900s. And as a result, childhood leukemia and other cancers dramatically increased. And they found that the results of taking measurements gave them no real benefit. By 1940, that stopped. Next is twilight sleep. In a minute, I'm going to show you a picture that is pretty disturbing. It became really common practice near on the later end of when twilight sleep was used. It's a combination of two drugs, scopolamine and morphine. And basically what it did was make the mother have amnesia, and it was repeatedly given throughout her labor. It started with Queen Victoria, who was the first recipient, and when news came to America, all of the moms were clamoring for it because it was the first significant pain treatment during labor. Here's the downside. It didn't really get rid of the pain. It only gets rid of the memory. And that drug is given all the way until after the baby is born. So thousands of mothers didn't remember being in labor, but they didn't remember the birth of their baby. Unfortunately, the combination of those two drugs made women more primal There were reports of mothers thrashing and screaming and biting medical staff, so they tied them to the bed so that they wouldn't go anywhere. But they were left alone, so that meant that they couldn't get up to go to the bathroom. And in the meantime, because of all of the thrashing and being bound to the bed, after the birth, the husbands were really curious about why they had these bruises. Women's heads were covered because they were also spitting. The bounds that were used to restrain them were lined with lamb's wool to reduce bruising. It still didn't improve the fact that moms didn't remember the birth of their baby. So twilight sleep essentially lasted from about 1910 to the 1960s. The next was a drug, thalidomide. It was used for morning sickness to treat nausea, especially during the middle of the 20th century in the 1950s and 60s. Bad side effect. A lot of babies were born without fingers, hands, arms, toes, legs. Needless to say, it was very distressing, and the orphanages were filling up with these children that parents didn't feel equipped to raise. That didn't last very long. It stopped about in the 1960s. The next was DES. We'll just call it DES because that's what everybody else has called it. This was a medication used to help women keep from miscarrying if they had a history of miscarriage. This was used especially between 1938 and significantly 1971 because it was causing a return of childhood cancer. Next, as more and more tools were used inside laboring vaginas, more and more doctors saw the need to make room for these tools. There was a comedian in the 1970s, I think, is when he did this comedy concert, joked about, man, get in there with the salad spoons. That's what they looked like. A wide variety of forceps were developed. This was for reaching in and grabbing the baby's head and pulling the baby out by its neck. Needless to say, the lesser side effects were bruising on the face, but it also led to significant Bell's palsy for children. Some were temporary and some were permanent. On the other end, side effects included brain damage and death. This also led to the development of vitamin K because this particular birth had a tendency to cause brain hemorrhages. Lots of obstetric tools were developed starting in the 1700s by the Chamberlain family. Several of them were doctors, and they were very protective of these devices they had developed. But by the turn of the 20th century, 18 to 1900s, they started releasing these tools for other doctors to use, especially for the purpose of being able to expand the medical industry. Get back to that, vacuums were developed. Now this required not only access to the baby's head to be able to see it and get to it, but you also had to rupture that membrane to be able to get a secure suction on the baby's scalp. Did some similar things to the baby that forceps did by pulling on the axis was the baby's neck, by pulling the baby out. But it also caused big hematomas. Again, you need vitamin K because babies are born with lower clotting factors so that their blood can circulate better and they can get oxygen better because their oxygen source is in their blood. It's not in the air. Vacuum use decreased in the 1980s. They were especially used between the 1950 and 1980. Episiotomies were very, very, very common. They were done in almost every birth between the 1920s and the 1980s. The only time that an episiotomy was not used was when the baby was just coming out right now. We don't have time to do an episiotomy. Luckily, that has dramatically decreased. Very few women have episiotomies now because science has found that it changes nothing. I think it was just a doctor's opinion that it was causing brain damage for the baby to pound against the perineum. And this is the perineum. This is the outside skin. It's skin. It's not anything more than skin. Skin can tear when it needs to. It does not need to be cut. Cutting, unfortunately, caused a lot of problems for moms, depending on Almost every episiotomy would rip further, and that's what caused the biggest amount of damage. Is it would rip all the way, I'm just going to be nice about it, it would rip all the way down. And that kind of repair and the recovery involved was... Next, enemas and shaving started fairly early into when physicians started going to birth. A lot of birthing people poop when they give birth. I've heard many midwives say whatever is in front of the head has to come out before the head. So the doctors didn't want to have to deal with the poop. They were convinced that they could make things better by having an enema, have the mom poop beforehand. They also shaved because almost everybody was having an episiotomy, and to this day, any time that someone's going to be stitched back up, it's shaved first if they get a chance to. Enemas and shaving happened primarily between the 1920s and the early 1990s. Separating the baby. The beginning was mom under twilight sleep didn't have the capacity to take care of baby, so they needed to tend to the baby for the mom. But over time, it also became a way of, we'll just give you a break. If we take the baby, you can sleep and do whatever pediatric care without interference. If you see any old shows about a birth, they have the visiting room, big old lines of babies in beds, always separated even if they're twins, and a viewing window unless visiting hours are over, but anybody could walk by and admire the babies. Ending separating the baby started about in the 1990s. Eventually they came up with this term of rooming in, letting the baby sleep and be with the birthing parents the whole time that they're in the hospital unless otherwise necessary, and now it's just common practice. So the first cry, as a birth worker, I have been torn about this subject for a long time. Yes, medically, the first cry is very reassuring that the airway is clear, that they're not going to be dealing with lung issues immediately, because some things can develop later. But at the same time, crying means distress. It doesn't mean anything else. That's a baby's language. That's their only language until they learn otherwise, until they develop skills in bonding and attachment and interaction with parents. That's the only language they have. If a baby is crying, they need help. They need something. It was very, very popular in the 1950s. It was called the SWAT. The obstetrician would pull the baby out, grab them with their two fingers, and grab the baby by the ankles and hang them upside down. If they did not immediately cry, they would swat the baby's back, and that pain would cause them to cry. Just feel so bad for that baby. Don't beat on babies. This has become a second item in my hard to find list. I could spend hours hunting for something when I'm a dog on a bone about a subject, and this has become a second one of mine. There's not much that's easily findable anymore about the SWAT. Like I said, it was very, very common in the 1950s. If anybody wants to suggest a TV show or a movie where this was used, because it was common in entertainment for this to be shown. The SWAT ended in about the 1960s, especially as moms were not using twilight sleep and could participate and remember their birth and watch the doctor doing it. It was a big shock. Okay, we're going to get into some stuff that's still happening. Giving birth on your back. This has definitely continued because of the convenience for the doctor or the midwife, anyone, that giving birth on the back gives easy access to everything. Legend says that birth started happening with a woman laying on her back because a French king wanted to watch the birth of his child. At the time, males were not allowed in the room at all, so he hid behind a curtain. Here's the problem. In a female pelvis, you can easily see that this is a joint. That is not a fused bone. And during labor, and my pelvis has not had enough relaxin to work well, this bone will flex out and make space for the baby coming through. If a birthing person is laying on their back, it is harder for that bone to have enough space. It's not impossible. It's obviously happened many, many, many times. C-sections. Legend has it that Julius Caesar was the first C-section, and so cesarean section was the name of the practice. I don't know how true that was, but C-sections have been done for hundreds and hundreds of years. If the mother died, the first option was open up the belly, check and see if the baby is still alive, and find a way to save the baby. Over time, the C-section has been modified. It has become quite safe surgery to do. Now moms are even allowed to be awake during the birth of their baby under these circumstances. The incision is buried right above the pubic bone, so you can still wear a bikini and it's not real noticeable. So C-sections still happen, especially since the 1940s. Part of the problem with C-section, it is the reason why birthing people in the hospital are not allowed to eat during labor.
What?
Don't eat during something that's been equated to running a marathon? Don't eat? Are you serious? This makes no sense. Why does this make sense? This doesn't make sense. The only reason why it's done is in case you need a C-section from the time that it's noticed until the time that it happens. That could be, well, quite frankly, unfortunately, it could be an hour for emergency C-sections, but a true emergency C-section could take 15, 30 minutes. So if you ate 30 minutes before that happened, it's only been an hour until that surgery, and you know how it goes with surgeries. You don't eat after midnight because of aspiration. That research I'll get into in a future video. So, especially starting in about the 1950s, that's when medications became introduced into obstetrics and practiced on women, many times without real research. To get labor started that hasn't started, which is called being induced, or augmenting labor, which means your labor's not going fast enough, we need to make it go fast enough. Refer back to Friedman's curve. The problem with this is it's not part of the natural physiology of labor, so the experience is different. The chemistry is just different, no matter how close to oxytocin you get. The problem is when you induce on someone who's having a VBAC, which is a vaginal birth after C-section. So for instance, if someone had a vaginal birth after 2 C-sections, it would look like this. Inducing plus a VBAC can be dangerous. VBAC is not dangerous. Inducing and VBAC is dangerous. So this gets into the era of Pitocin, Cytotec, and Sorbital. The hospital tries to call it oxytocin. It's never oxytocin. It's always Pitocin. No one has found out how to recreate oxytocin without natural stimulus, like a kiss or a baby or a puppy. That's how you get natural oxytocin. Cytotec's other name is misoprostol. Sorbital's other name is dinopristone. Cytotec being used on pregnant people of any stage of pregnancy is a black box warning. I'll get into those in a future video also. Needless to say, it basically means don't use it on them. It was originally researched as a treatment for ulcers. like I said, VBACs plus inducing medication dramatically increases the chances of bad things happening, especially Cytotec and Cervidil, which are used a lot less now. Thank goodness, because it caused a lot of deaths. Cervical stripping. Getting into the last few, and I'm just mentioning these because they are regular practices that happen at hospitals, and anyone having a hospital birth needs to know that these are possibilities. Your doula can teach you about these things. If you don't know what a doula is, there's a video linked down below where I discuss that. Cervical stripping. There is, I don't have, how do I not have a, I might have a model for this. There's my uterus. This is a uterus. This is a C-section. This is a cervix. Because the cervix is the very bottom part of the uterus. It's small. It's a little button. And it's what has to open to let the baby out. It is a muscle and a sphincter. It is not just a muscle. Cervical stripping is the cervix has to be open at least a finger size. And the finger is used to loosen the space between the cervix and the amniotic sac. There tends to be like a little bit of fibrin connecting the two of them. It's not like any strings or anything. It's just, it's kind of like if you had spit on your tongue and you pulled your finger away and the spit came with it's all fine. It's not actually needed. But there has been some research that the cervix itself is really sensitive during pregnancy, increasingly through the pregnancy, quite obviously. And contact with that cervix makes the whole uterus interact. So it can release prostaglandins, which can stimulate labor. There's no guarantee of this working, but it's used a lot. Down below, we'll link a video called Maternal Health Without Consent. Way too many women are experiencing cervical stripping, cervical stretching, cervical sweeping. There's several words for it, but way too often this is done to women without warning, without consent, and sometimes against consent. This is called sexual assault, and it needs to never happen. Rupture of membrane, the artificial rupture of membrane. Can I break your water? You saw in the previous video, water's not breakable. Say this with me, water's not breakable. Let's break your water, it'll make labor happen faster. Research says that's not true. If it happens faster, it's a coincidence. Rupturing the membrane does not guarantee a faster labor, and the research shows it. Okay, the last one, and it was probably my first personal beef about maternal health care. Constant electronic fetal monitoring. Midwives use this for home birth, consistently checking heartbeat every couple hours or less, depending on what's needed. Home birth isn't without safety, but hospitals discovered it first. They would strap a transducer to the belly to detect baby's heart rate. And if mom moves at all, that heart rate can be suddenly undetectable, and everybody gets concerned. Luckily, not as much in recent decades. But research has showed that constant electronic fetal monitoring does not improve anything. And there were some incidences of C-sections performed unnecessarily because the baby was absolutely fine, despite what the heart rate tracing is saying. Okay, that was a lot. I have not even touched anything having to do with the experience of indigenous people, people of color, except for my comment at the beginning, disabled people giving birth. I will say that all of those categories have experienced in previous decades being sterilized without consent or knowledge. So at the end, I'm going to list some names of some great professionals to research their information if you'd like to expand your knowledge on these subjects. What's up next? I've been looking forward to this for months. There is a movie that was released on Netflix, and that's all I'm going to say. But needless to say, it's a reaction video, so I'm looking forward to sharing that with you. I need my own reminder because that was a lot of stressful information. These are a long list of gripes that I've had about not just the field, but the industry for a very long time. So I will just end by saying, please remember to be kind to all of your fellow human beings, no matter their diversity.